heart failure in everyday life as well. But when it comes about the treatment, there's a lot of confusion, right? So, what are we supposed to give? What are the drugs we are supposed to be giving? So, there's a lot of confusion about it. What kind of drugs should be given? How to up titrate is as well. Which are the drugs which is going to be helpful for those patients as well? That even becomes more confusing as well. So that is what we are trying to focus upon today. That what shall we be taking care of, in fact, okay? So I think there has already been a lot of talk as well. So what kind of medicine shall we be using for these drugs, in fact, right? In the sense, we all are very much aware of the age-old drugs. So, for example, which has been there since a long, long time, which one we can always be giving for these patients. So we all are aware definitely like the ACE inhibitors, the ARBs, or uh, the beta blockers, and also the diuretics. But one of the key things which we all should keep in mind is, are they going to be beneficial? Is it going to give them mortality benefits or not? So that is what should be the aim, and that is the main point which differentiates between a good physician and a normal physician. Okay, so and once someone is the patient is doing already stable on ACE inhibitors or ARBs, that is the time, and with of course good blood pressure and the GFR is also good. Okay, and after only when the ACE inhibitors are have been stopped for at least 36 hours, then one can consider them to switch over to the ACE inhibitor, the ARNI, in fact, okay, and one can also add according to the need the proven drug therapies like the aldosterone antagonists, the ivabradine as well, the isorbit dinitrate as well. And one of the key things always is make sure there are no contraindications for that. One of the most important things whenever we are trying to treat such kind of patients is titrate. Why I'm telling about this is, yes, we start the drugs, the medicine, but we do not titrate often. So that is why titrate the diuretic dose over days to weeks to relieve the congestion, and also you should consider increasing the dose of ACE inhibitor, ARBs, or even ARNI as well to the maximum tolerated dose every 2 weeks until you get a target dose. So, one of the key things is, when do you really need to refer to a heart failure specialist? Okay, so I need help. So, what does it stand for? I for intravenous inotropes, N for NIHA class 3B or 4, or really, really symptomatic. Otherwise, if you have done the blood investigations and there's still persistently elevated natriuretic peptides, E for end organ dysfunction. Otherwise, also E for ejection fraction is less than 35%. And the person someone has already received a lot of defibrillator shocks as well. And the patient has had more than one hospitalizations. And if you notice, there's edema in spite of escalating diuretics. And L for there's low systolic blood pressure less than 90. Otherwise, if there's high heart rate. Similarly, P is for prognostic medication. So there's progressive intolerance or down titration of the guideline directed medical therapy, GDMT, what is called as. So I think now it is going to be there definitely with all of you forever. So one of the other important thing, what is called as care coordination. In fact, more than 50% of the heart failure Medicare patients have four or more non-cardiovascular comorbidities, and in fact, more than 25% have six or more, raising the risk of insufficiencies of the care delivery, miscommunication, potential drug to drug interaction, drug disease interaction, and the missed opportunities to achieve optimal outcomes. So, this is the reason why team based care is said to be the most effective approach. In fact, team based care by definition is delivery of health services to individuals, families, and or their communities by at least two healthcare providers who work collaboratively with the patients and their caregivers in concordance with patient preference to achieve shared goals within and across settings. So now you're doing all these things. So, what is the next thing we should be bothered about? Adherence. Adherence is, you should try to understand what are the possible reasons of non adherence. In fact, it does include the patient factors like the patient health literacy, perceived lack of affect, depression, social isolation, cognitive and physical impairment, medical condition, for example, like the polypharmacy due to multiple comorbidities, and the therapy, for example, about the frequency of dosing, the side effects, the socioeconomic conditions like the out of pocket pay, different or difficult access to pharmacy, and even health system. For example, if there is poor communication, there's uh, incompetent or lack of care, or no automatic refills are there for those patients. So this is the reason why nowadays the language from patients' compliance to adherence is being much more stressed. And we are also telling more about the activation, engagement, and empowerment. And the patient definitely needs support. And always remember, blame is counterproductive. So, we should be able to capitalize on opportunities to improve adherence. And that is why specific patient interventions like the medical education, disease education, teaching of self monitoring, self management, and use of mobile health in the form of reminders, warnings, and adherence tracking is very important. So, what happens is, as I was talking about those capitalizing on opportunities to improve adherence, such as pre discharge initiation of GDMT, which I said it, simplifying the medication regimens, communicating with other clinicians which are involved in care, consideration of costs and access, recommending tools that support adherence in real time, like the pill boxes filed by caregivers, or even anticipating the problems, like what about the refills? Then considering behavioral supports like the motivational interviewing and monitoring adherence in those at risk. For example, carrying out the medicine reconciliation and assessing the remaining dosage units, monitoring the pharmacy refills, and also reviewing the drug levels such as the digoxin, INR, also the anti-PREO BNP or the BNP levels, or even home-based nursing visits. So, whenever this treatment, Abdul, can you please mute your microphone? Abdul, please mute your microphone. Okay, now coming to the specific patient cohorts. So, why are these so special? For example, like African Americans, there's a higher risk of angioedema with ACE inhibitors or even ARNI, in fact, with them. And it is like 0.5% with the ACE inhibitors and up to 2.4% with ARNI. However, this should not preclude initiation of these agents absent a documented history of angioedema. Also, there are no data for efficacy of ARNI and ivermectin in population. So you should be a bit more careful whenever we are thinking for the ivermectin in such kind of patients. Similarly, whenever the isorbit dinitrate is being thought of, or hydrolazine in patients with low systolic blood pressure rather than ARNI should be considered. And this expert consensus document recommends the shared decision making with the patient. Then, what is the other specific patient cohort, like elderly people. What happens is the upper range of clinical trials with the GDMT has been 75 plus minus 5 years, and there is no data for drugs or devices in patients more than 80 years of age. There is a high risk of adverse events. An optimal dose in such patients may be less than maximum tolerated dose in younger physicians. The risks include falls, worsening renal function, polypharmacy, costs, and comorbidity. In fact, the frailty as well. Some of those patients, in fact, what happens 20% of those patients who are more than 80 years are frail. And in fact, the response of GDMT is uncertain, and ability to impact overall natural history is very, very unclear. Whatever we may be doing in, I know in UK, the cost of care using the NHS, they don't have to pay for this, but there is always a cost which is involved. What happens is the cost of cardiovascular medications is the second most important for the patients with heart failure, after, of course, the hospital costs, which accounts nearly for 16% of the direct costs. So the strategies for managing costs is important. For example, we should coordinate the care, including the labs and imaging, which results among the clinicians. Similarly, consider the limitations of medical coverage. Using generic equivalents of any GDMT, split the tablets without reducing the dose whenever appropriate, because this is going to also bring down the cost for those patients. And also, we should try to work with pharmacists to help patients navigate the patient assistance programs, and also, if possible, request price matching if a drug is found at a lower cost at another pharmacy. So, how to manage the increasing complexity of heart failure? For this, there are various guiding pathways, which include the target dose. Target dose is associated with the best outcome, in fact, and the top priority should be assigned to addressing factors that limit the GDMT, for example, like worsening azotemia, hyperkalemia, or even hypertension as well. The another guiding pathway includes optimal sympathetic nervous modulation by using the target dosage of beta blockers and lower dosage of renin angiotensin aldosterone system blockade when limited by hypotension. Similarly, before considering a ephedrine, we should try to optimize the beta blocker dosage. Okay, then we should add a hydrolysine or isorbate dinitrate in NIHA 3 or 4, especially African American patients, on optimal dosage of other medications whenever it is being given. So let's not forget this special group of drug in this special group of patients as well. And yes, if the optimal dosage of the medications has already been given and they are still symptomatic, we should consider about the device therapy like the ICDs or even the CRTs. Then the symptomatic congestion should be treated with diuretic irrespective of the other therapies. And the beam-based care approach should be optimized, for example, with the electrophysiologists, experts, nurse pharmacists, and also try to involve nephrologists as well. One of the other things is tolerability and side effects can be minimized by a key concept, what is called as start low and go slow with up titration, and focus on patient's symptoms and functional capacity as well as improving cardiac function. So this is something very, very important. As I said, the key is start low and go slow with the up titration. So how to manage the comorbidities? It includes, one of the key things is bidirectional relationship. So what does it mean? It refers to between the relationship between and the heart failure comorbidities, whereby the presence of one increases the severity of other, and prognosis is worse when both are present. Important cardiovascular comorbidities with association in parentheses include coronary artery disease, which is quite a lot often present, AF or flutter as well, very oftenly a strong correlation is present with the other factors like mitral regurgitation, aortic stenosis. Although with hypertension, dyslipidemia, peripheral vascular disease is a little uncertain. Cerebrovascular disease and peripheral vascular disease, I'm sorry, it is moderate. Cerebrovascular disease and peripheral vascular disease, it is moderate. Similarly, non-cardiovascular comorbidities include obesity, for which it is moderate inverse association, chronic lung disease, for which it is strong, diabetes, the strong, chronic renal disease, it is very strong, and also strong for iron deficiency or the hypo or hyperthyroid conditions as well, it is strong. Okay, although for anemia, it is moderate, and sleep disordered breathing as well, it can be causing all these problems. So, targeting comorbidities does not uniformly improve the heart failure outcomes, but it is important to so to improve the overall patient outcomes. So that is why we should be taking care of those the comorbidities as well. Similarly, about the palliative or hospice care. So such consultations can be helpful in ameliorating the refractory symptoms as fatigue, dyspnea, pain, and in managing complex decisions. So that is why the soliciting goal of care and focusing on quality of life and meticulous management of heart failure, particularly diuretic therapy, and patient decision aids and decision support to help patients to frame options and also follow up with dynamic and personalized conversations. So, what are the other things? Other things includes preparedness. Preparedness includes planned discussion should occur annually to review current therapies and for clarification of patient values, beliefs, anticipation of treatment decisions, and advanced care directives as well. Similar preparedness. Similar preparedness includes planning discussion should occur at time of major interventions such as LVAD or even heart transplantations. The next important factor is clinical trajectory, particularly milestone event. Attention to the clinical trajectory, particularly milestone event, recurrent hospitalizations, and intolerance to medications due to hypertension or kidney dysfunction should trigger heightened preparations with patients and families, but without specific estimates of how much time is remaining due to high levels of unpredictability in the clinical courses of heart failure. In fact, the transition from do everything to comfort only hospice is often bridged by a period of survival, which involves revising the GDMT, for example, like you can even deactivate the defibrillator therapy, also addition of therapies, usually which is not recommended. For example, we all are aware about the usage of opioids for refractory dyspnea.